So we'll move now on to hoping that sometime in our future we will be able to make these RILs redundant by preventing patients from reaching such high myopias. So this part would be a set of hopeful thinking on our part that we may be able to catch them younger and be able to prevent this from happening. So first question is for us to know that is it such a big problem? And while in India we, for two possible cases, don't have not till yet been concentrating on it. One, because we are actually not thinking about it so much, and two, probably it is still not so much as we expect it or see it in the East Asian countries. But there was this study which was really an eye-opening study, which was published by the Brian Holden Group in ophthalmology, which talked about the global prevalence of myopia and high myopia and the temporal trends from 2000 to 2050. So it was a predictive trend analysis that they made, and they said that in 2000, about 22% of the world's population was myopic, and 2.7% was high myopes. But by 2050, nearly 50% of the world's population will be myopic, and nearly 10% of them would be high myopes. So besides the RILs, they would really be requiring a lot more intervention, particularly related to the retina. So the question is that is it really a problem for us in India? Because till now, really, except in the past a year or so, myopia was the only thought process of an ophthalmic surgeon was that it's going to give me some more money. But now we are really concerned that we should hopefully not go the way of East Asia. What we could see was that while this was one of our studies which we had done, which was a prevalence of myopia study in a school children, which was published in PLOS One first, and we found a 13.1% prevalence in school children. And when we compared it to the close to 50% or 80% in some East Asian nations, we thought it's not such a big deal. But when we looked at the incidence, we followed up the same group of children of about 10,000, and we found that the cumulative incidence was about 3.3%. But again, it didn't look so, so devastating compared to 4 to 14% in some East Asian countries. So, is it really a cause for concern? But again, if we use some projection, we realize that if there was an incidence of 3.3% cumulative over the next decade, we would expect that more than 30% of our children would actually be myopes. So if there is a 3.3% incidence, you'll know that every year this is going to progressively increase. So we are expecting that things will start getting worse. So the importance is to realize that we need to do something about it. The second thing was that in the same place where we had done this survey, almost more than 10 years ago, a similar survey was done by RP Center in that same place, and we found a 7.1% prevalence. So you can see that it was nearly a jump of a doubling of the prevalence in the same area over about a decade. So two things, it is happening in India, and we are not genetically kind of immune to it. This was a study which was done on first generation, second generation Indians, and who had immigrated to Singapore, and the first generation had about 12% of myopia, and the second generation immigrants or the children of these immigrants had almost 28%. So again, as a race, we are not really immune to this. There are major problems besides the learning ability, retardation, doing poorly in school, sports, and others, suffering of injuries. There is the long-term problem of strabismus, amblyopia, and pathological myopia. The other problem is that although the intervention, especially in children, looks very innocuous in the form of spectacles, but a previous study had said that the cost of just spectacles in the US was close to $4.6 billion per year, and you can think what cost it would be in India. So based on the studies and the work that has been going on, and there is a lot of interest in this, particularly in East Asia, where we are seeing close to an epidemic of myopia, there were some major risk factors which we also found out in the children we had evaluated. So one was a very surprising thing. It was a school type. So we had actually taken two groups, both government schools and private schools, and unfortunately we found our children who were studying in the private public schools, as we would call it, had the prevalence was more than double than that of the government schools. It was about 4 to 5% in the government schools, and it was more than 20% in the private schools. So school type essentially was important. Family history, of course, was important. Socioeconomic status kind of gelled with the school type actually, because they were seen far more in the affluent group of children. Those who did a lot of reading, writing, and video games, and outdoor activity, which has been consistently now being seen was protective. I mean, found that children who spent about 2 hours a day outdoors and not necessarily playing any sports or games were protected from the prevalence progression of myopia. So, parental myopia extremely important as a risk factor for development and progression of myopia. And demographically, the other thing we found was that girls were more likely, at least in our group, and a lot of studies have actually found girls to be more likely to develop and progress myopia. And with higher education, the prevalence is significantly increasing. One of the thoughts behind, especially in East Asia and the urban epidemic that is happening, is that they are living in constricted spaces. There is no zero horizon, there is no infinity to see and the eye to actually relax. And the constant indoor activity and close work increases the risk of myopia. So it's the use of accommodation which is one of the hypotheses which is considered to be responsible for this. The other is the light dopamine hypothesis, that going outdoors actually resulting in the release of dopamine on exposure to light more limits or manages the progression of the elongation, the axial elongation of the eye. So management can be spectacles, contact lenses, progressive ad lenses, orthokeratology. So I'll just run you a few of the basic ideas for management, and of course the pharmacological modulation will be in the following conversation. So there are a lot of spectacles. So we know that unifocal spectacles do not help, but there are two kinds of spectacles that have been evaluated. One are the progressive ad lenses. We know that these myopic children have an accommodative lag, so they are having difficulty in near vision. There is a little difficulty in near vision. Because of that, possibly the eyes are growing longer. That's a stimulus. So there is a blur when they're looking for near, and that causes axial elongation, resulting in the myopia from developing. So an accommodative lag exists in these children, and therefore by giving progressive additional lenses, there is a hypothesis that we may actually be able to prevent the myopia from happening. The other thing is the other concept built was a peripheral additional lenses. So it was current monofocal spectacles actually correct you for central vision, but as you go to the periphery, there is a hyperopic defocus. The globe is not a perfect sphere, so there is a peripheral hyperopic defocus. Again, is considered to be a reason for the eye to elongate for the defocus and correct for that. So therefore, peripheral additional lenses which create a peripheral myopic kind of a refractive error that prevents the elongation. So again, these are lenses that are under trial, not only as spectacles but also contact lenses, and a fair amount of improvement is seen in this. The others are bifocal prismatic additional lenses. So besides that, some children who have oculomotor anomalies like esophorias or exophorias are also seen to progress rapidly in their myopia. So some amount of prismatic correction along with the bifocals has been seen to significantly reduce myopic progression. Soft contact lenses, of course, just unifocal soft contact lenses are not found to be useful, but bifocal contact lenses and of course orthokeratology, which I'll be talking about. So soft multifocal contact lenses is the other thing which is again showing that there is a significant reduction in the progression of myopia. Orthokeratology is something which initially came just to correct myopia, but over follow-up it was found that it actually prevented the axial elongation. Now, how it actually did it or just prevented the cornea also from steepening up, we are not very clear, but it is again known that the moment you stop orthokeratology, the rebound occurs and the eye again starts elongating and getting myopia. Pharmacologically, any other form of medication has been tried, like timolol, pyrazipine, but the only drug really to be effective is atropine, and these are this, and along with a couple of series of some wonderful trials done from Singapore have led us to the concept that probably low dose atropine will help, and my subsequent speaker, Dr. Lipika, would be talking about it a little more in detail. The other thing that is important is the role of environment, and we know that outdoor activity significantly decreases. And these are all the various summarizing, but I'll just show you in this table. You will see basically myopia progression, what works and what does not. So ones that are higher up on this graph are more likely to be effective. So most effective currently is atropine, orthokeratology while you're doing it, prismatic bifocal lenses, and progressive additional lenses. So these are currently known to be very beneficial. Time spent outdoors is still under study, but adequate evidence has been piled that there is adequate evidence that outdoor activity is definitely protective, and this has been now substantiated by a lot of cross-sectional studies. There are 2 or 3 interventional studies where outdoor activity is being tested, including one which we are doing in Delhi. But of course, an absolute impact per hour or study is yet to be established. So where are we? The key is increase awareness about myopia in the next generation. We are sure that outdoor activity works. Atropine, how effective it is in our Indian population, we really need to accumulate data and understand its effect, particularly the long-term effect on the eye and the growth of the child. We know about peripheral additional lenses as well as ortho K. So we are still looking at and evaluating and understanding myopic progression in children and how we can prevent progression and halt it so that they do not become high myopes. Thank you.